Good evening. I'd like to welcome you to the COVID-19 webinar series for this evening. My name's Cliff Shim, and I'm one of the Vice Presidents of the Royal College of Surgeons of England. I think we've got a really important topic to discuss tonight, and I'm sure it will generate a lot of questions and comments, and that's the impact of COVID-19 on the BAME workforce. And we know that's a major issue at the moment. 1 in 5 of our healthcare workforce is from the BAME community. So I think it's a really important issue. Now, I'm joined this evening by 3 panelists. Tim Cook, who's Professor of Intensive Care and Anaesthesia in Bath, and also, as I'm sure many of you will be aware, the author of the 2 Health Service Journal papers, one on the 22nd of April and one on the 5th of May yesterday, which has really highlighted this issue, and Tim is going to discuss that in a bit more detail in a minute. Ananda Nanu, who's an orthopaedic surgeon and the past president of the British Orthopaedic Association from Sunderland, and Professor Farah Bhatti, who's a cardiothoracic surgeon in Swansea, and who's also going to give us a little bit of background on what the Royal College of Surgeons of England has done so far to address this issue. I'd also just like to thank, while we're here, Lucy Davis, Jane Roberts, Tamara Langley, and Misha Mafana, who've actually made this webinar possible, and it's no mean undertaking, I can assure you, so I'm very grateful to them. I'd like to just start off by running through a little bit of background on the slides. If I could have the next slide, please. Just to show you some of the information and material which has already been put out by our college. I won't go into great detail, but it's all available to you on our website. So if I could have the next slide, please. And I think this is a particularly important piece of work which was put out last week, as we're now moving into what seems to be like the recovery phase of this crisis, and how elective or non-emergency work will start up, recommendations for how surgical teams should address this problem. And again, these are just the key areas which recommendations and guidance has been offered to you, which I hope you'll look at and be able to use. So you could have the next slide, please. Also, too, we know that things are far from perfect. We looked at the last survey, which we obtained data from last week. We know that 1 in 3 of the surgical workforce is still working in an environment where they feel they haven't got adequate access to PPE. As I'm sure we'll talk about in a minute, PPE seems to be very, very much the key to everything that we're doing at the moment. And that might be something that some of you might want to question. So, just to conclude this first introduction, we're going to try and sort of think about this session in 3 sort of main chunks. We're going to look first of all at what do we know about the problem to date. We're going to talk a little bit about what measures can be taken, should be taken, and are being taken. And then hopefully talk a little bit about what this means for the future, the intermediate and short term, as we will start off doing more surgery now, hopefully over the next few weeks and months, but also too in the longer term future, what these findings might mean for our workforce. So I hope it's a session that you'll get a lot out of. I hope you'll be able to engage and send questions in. And when we can, we'll answer them. But equally too, we're very keen to hear your views and comments, because that's how we can actually formulate our ideas of how to represent you and your feelings and thoughts on this topic. So what I'd like to do at this stage, if it's okay, I'm going to hand over to each of the panelists just very briefly to introduce themselves. And then Tim will give us an overview of the data that he has access to. So perhaps, Ananda, if I could just start off by asking you to introduce yourself briefly. Thanks.
So I'm Ananda Nanu. I'm a council member of the Royal College of Surgeons. I head the SAS committee of the college, and I'm a past president of the British Orthopaedic Association. But more importantly, I fall into the category of BAME. I'm an active trauma and orthopedic surgeon, and I continue to work on the front line. Thank you, Cliff.
Thank you. And Farah, perhaps you could introduce yourself too. Thank you.
Hi, hello. My name is Farah Bhatti. I'm a consultant cardiac surgeon. I work in Swansea, still working on the front line. I'm a council member of the college and also chair of Women in Surgery. Thanks.
Thank you. And Tim, perhaps you could just give us a brief introduction, and then please, if you'd like to give us your data.
I work in Bath, do intensive care as well in Bath, and I'm an honorary professor of anaesthesia in Bristol University.
That's great, thank you. So I think you've got some slides to help us. Yep, thank you very much.
Yeah, so I'm going to go through the slides quite quickly. There's a fair amount of data to run through. About me, so you can see by my unshaven appearance, I'm shielded at home, and by my long hair, I'm shielded at home. I have a chest condition, so my department has sent me home, considering that I'm at high risk if I get COVID-19. And so I am aware of the relevance of this for other individuals who might be at higher risk. That has, of course, given me some time to look at the topic as well. I've listed there what I'm not. We'll come to that. Next slide, please. I should mention these colleagues. I'm not going to read their names all out, but they've been, it's interesting, of those, I only know Amira, really. The others, we approached the topic independently and found each other effectively on Twitter, searching for the same data, and then joined forces to analyze the data. Next, please. And I am very grateful for all those contributions from all of those members. I think there are two questions to answer. Firstly, are BAME individuals particularly affected by COVID-19 in the healthcare setting, and is there overall a healthcare worker issue? That's what we've tried to address with our two papers. Next, please. So it's a visible problem. One only needs to look at any newspaper, any website, and we see pictures of healthcare workers and social care workers who have died. It's not clear whether they've died in the course of whether they've acquired COVID in the course of their activities, they've died from or with COVID, but the faces tell the story. Next slide, please. There's also, it was raised as a concern. We saw some data from the United States and elsewhere, but ICNARC gave us a signal as well. So the Intensive Care National Audit and Research Centre, which identified that a higher proportion of patients from the BAME population were on intensive care at any given time, with particularly Asian and Black populations being increased, and a disproportionately low proportion of white individuals. Next slide, please. In order to, so these slides have jumped around a bit. The tabbing has not come across on the slides. But we need to understand the makeup of the workforce to interpret the data, and there is a lot of data available, but it's complicated to get through it. So there are about 125,000 doctors working in hospitals. There are at least 6 times as that many nurses, clinical support staff, and scientific support staff, irrespective of the infrastructure staff. Doctors account for only about 10% of the staff in the hospital setup, and this is just England. That's about 1.2 million members of staff there. Next, please. That's the same information shown visually, and we can skip through to the next one. So the workforce of the NHS is very dramatically, predominantly female. 3/4 of the workforce is female. You can see on the left side there that doctors are pretty much 50-50 male and female, but nurses, healthcare visitors, 90%, midwives, 99.6%, and the rest of the staff, again, predominantly female. Next slide, please. Of course, the UK population is 50-50, or as close as. And within the BAME populations within the NHS, so roughly 1/5 of the NHS workforce is BAME, and 18% are born outside this country, which we'll come back to. What is noticeable is that the proportion of BAME individuals is greatest amongst doctors, where it's approaching half. Next slide, please. So I've dwelled a little bit on the makeup of the workforce, but you can't interpret the data unless you know the population you're comparing it to. So this was our paper 10 days ago. Next slide, please. So there's a little bit of delay, so it's going to take, I think that's a delay on my audio, so it's going to take a little bit longer. Yes, so our source of data, that's fine. Our source of data was those websites where we got news, and also from Twitter, to identify and then corroborate unfortunately, I think, and the slides have been squashed, reformatted. They've moved around a little bit, so they are looking a bit clumsy, frankly. So we tried to corroborate each case by having 3 confirmed identifications in 3 different media outlets and 1 social media, usually Twitter outlet. And only then did we consider cases confirmed. And there were certainly some cases that we excluded, about 15% of cases we excluded, but 93% of cases we were able to completely confirm the information. Next slide, please. And we track there on so the black dots represent the overall mortality, the overall deaths in the UK. That's from hospitals at the point that this was reported. They were not reporting from outside hospitals, and that was 16,000 deaths up till the 20th of April. And you can see the red dots tracking in a very similar fashion, tracking the same epidemic curve, starting to tail off at the top there. Next slide, please. We can slip past that one. That just shows that the data was 96% complete, and the predominant individuals affected in terms of dying as a result of COVID, who were healthcare workers, was nurses and midwives and health support workers. Next slide, please. We can compare those in proportion to the workforce, and we'll see that doctors, so that where the blue line extends beyond the orange line, doctors are quite significantly overrepresented, as are nurses and ambulance staff. And of course, those staff who are less front line, that's others, and clinical support are less exaggerated in the data. Next, please. Coming back to that information on data, if we compare the proportion of, so it's a male disease. COVID-19 is a male disease. Roughly 57% of UK deaths are in males, but in healthcare staff, it's less than half from this data. In doctors particularly, so doctors, as I say, 55% are male, 94% are male amongst the healthcare worker, the doctor deaths. And you can also see that where those grey bars extend above the green bars, that's an excess of male deaths again. Next slide. In general, so remember, this is just the working population. So the NHS is a younger, so in terms of the employment, the age distribution within the workforce, the NHS is a young employer with more individuals under the age of 25 than most organisations. And some of the members, some of the people who died in this data series were really quite elderly, up to 84, still working. We need to remember that 70% of deaths from COVID are in the over 75s, many of whom we won't see in hospitals. But more than 70% of the patients, of the individuals who died while at work as healthcare and social care workers were aged less than 70. And you can see the median ages, with doctors being slightly older than the other groups, which is not altogether surprising. Next slide, please. We can skip past that one. That's just the table that shows the ethnicity and country of birth. So I'm going to show that in tabular form. So here we see a comparison between the proportion of deaths versus the proportion of that ethnic group within the NHS workforce. We see a significant excess across all workforces for BAME individuals. In nurses, health support workers and doctors, there's a dramatic increase in the proportion of individuals who are BAMing compared to the workforce. And the next slide, if we then add the overall population into that, we can see that when the next slide comes up, but it's perhaps even more significant if we add the population. And you'll see, for instance, in the Black and Asian parts of the graph there, that there's a disproportionate number of Black and Asian individuals working in the health service. So key workers are, as the Nuffield reported last week, key workers are disproportionately BAME individuals, and then we have a disproportionate excess of deaths within those groups as well. Next slide. It's a little bit clunky because of the time delay, so I apologise for that. It's a bit clunky because some of the slides have moved. In terms of medical specialties, we can see it's something that's going to focus the mind of many of the people on this call, on this webinar, that surgeons in that group of 18 individuals were the largest group of fatalities amongst doctors. Next slide, please, with GPs shortly behind them. We'll come back to that. And those were the specialties of the 5 individuals who died. And it's notable that so what's in that slide is what isn't in the slide is just as important as what's in it. So no anaesthetists, no intensive care medicine physicians who died. Next slide. So now move on to the second study that we did. We were criticised, I think not unreasonably. We were criticised because we said that the overall mortality rate in the healthcare workers was not similar to the whole population. And some commentators said, well, you should have age and gender matched it. So we tried to do that. It's quite difficult. So to get the information, next slide, please. So to get the information both for gender and sex for the population that we wanted to compare with, required getting data from all sorts of different sources. So getting the number of deaths in the English and Welsh population, reducing our population to an English and Welsh working age population, matching the dates, and also getting information on age and gender for healthcare workers as well. The adjustment factor, so if you look at the reasons people leave the NHS, then death in service is listed there. And the number of deaths in service are quite dramatically less than would be predicted from mortality predictors, age-matched mortality predictors. So we've used an adjustment factor because probably healthcare workers are more healthy to start with than their non-working counterparts in the population in general. Next slide, please. So we've therefore compared what we believe are alike populations. Next slide. And we've created a mortality ratio by gender and by age. I'm not going to read it out, but overall, so the mortality ratio is unadjusted, and then we've adjusted with that factor of dividing by 0.079, sorry, 0.79, to adjust for probably other factors which are not seen in the data, which make healthcare workers slightly healthier. Now, I accept that that's slightly controversial, but that's what we've done, and it may not apply equally across all age bands. And the most notable feature is the excess mortality of perhaps twofold, which we need to interpret very cautiously in the younger band of females. Next slide, please. And all the other groups, there doesn't appear to be an excess mortality, which overall is generally reassuring. There is criticism. I would criticize what we've done. We've got rather limited data. They're very small numbers. The data is therefore fragile, and we've not performed any statistical analyses. But if we've had any missing data, that would drive those ratios up. We've made assumptions about age where we didn't have age, and we generally reckoned that people were older than they looked. So that would drive the ratios up, particularly for the young. And we've assumed that every member employed in the NHS was equally affected, whereas in fact all our deaths were in patient-facing individuals. So we could potentially reduce the NHS population we compared to by about 40%, which would increase our ratios by the same amount. Next slide, please. So I think our data and our interpretation is reasonably cautious. Just the last couple of slides, updated data sets. So we're now up to, mainly thanks to Simon Linnane and Ella, we're up to 190 potential cases, 157 confirmed cases. You can see the spread across there. We can slip onto the next slide and then probably quite straight across to the next slide. So no particular regional distribution, it hits the hotspots. The Philippines has consistently been overrepresented, as those other countries have. There are about 40,000 Filipinos who are contributing to the healthcare. They are a significant proportion of our frontline healthcare workers. And I think the next slide is what is the next series of slides, which is the doctors in that series. So 25 doctors. Still only one white individual in this group, predominantly male, predominantly BAME, and predominantly towards the end of individuals' careers. Again, no anaesthetist and intensive care medicine doctors. There is one intensive care nurse who sadly has died, and that forms part of about 160 patients. Next slide, please. That is the focus on the surgeons. So the only notable thing in that slide was that the additional surgeon is a plastic surgeon. So we can answer those two questions. The first one is, are BAME individuals more affected? You don't need statistics, you need spectacles to confirm that. The answer is clearly yes. Is there a healthcare worker issue? I think the answer is uncertain. And the whole point of us doing this, what I think is a somewhat scruffy but necessary analysis. It's scruffy because the only data we had was scruffy. We've done the best we can with it. The whole point of it is to point out that what we need is better data. Data collected centrally, analysed and reported so we can get reliable information about this group of individuals. And I'll finish there.
That's great, thank you, Tim. I mean, whatever you've done, you've drawn attention to this really important problem. So just while Lucy's getting questions organised, perhaps if I could turn to Farabati just to outline to everybody what the college has done so far to address this issue. And it was one of the questions actually we received before this evening, so it'd be useful to address that as well. So thanks, Farah.
Thanks, Tim, for that, presenting your data. And I think there's clearly emerging evidence, not just from the UK, but from international sources, that people from BAME backgrounds are being disproportionately affected by COVID-19. And I think not just, and I think the data you've shown is quite stark that you presented in your healthcare journal. So a fifth of the healthcare staff are from BAME backgrounds, and yet 63% of deaths are people from BAME backgrounds. And that's even starker with doctors. 44% are BAME background, but they account for 94% of the deaths. And other people have been studying this, not just in healthcare workers. And the Institute of Physical Studies produced a quite lengthy report, and in there they adjusted for age and geographical location, but they concluded that clearly BAME, we're not all the same, but they found that Black Africans had a 3.7 times higher chance of being susceptible to COVID death. Pakistani groups, 2.9 times more likely than their white counterparts, and Bangladeshi community 2 times as likely than their white counterparts to succumb to COVID-19. So what's the government doing about it? Well, they're going to start recording ethnicity, or I think from this Friday, they've ordered a Public Health England review, and that's due to report at the end of May. But clearly we can't wait until then, and NHS England CEO Simon Stevens has actually written to all trusts to advise them to take a sort of precautionary approach in terms of assessing people before we get all the evidence, because the reasons why BAME people are succumbing to COVID isn't clear, but we need to do something. What we are clear about, that we need to do something now. So what's the college's response? Well, clearly it's a sensitive issue and an important issue, hence this webinar. We're very concerned. We welcome data collection, but we're also really keen that the precautionary approach is used and risk assessment is carried out promptly between individuals from trusts or health boards in Wales and Scotland, so that you can each individual from the BAME community can be risk assessed, including where they're working, what kind of issues, comorbidities they may have, and then individual decisions made as to how best to protect that person, whether that's enhanced PPE, whether that's moving to different areas. That's an individual discussion, but we really advocate that that goes forward quickly, because we can't afford to wait. Okay.
Thank you, Farah. And I think it's important, isn't it, to emphasise, it came out in our guidelines last week that, from Tim's data, the one thing that stands out is appropriate PPE for all the surgical workforce and the team, including those with higher risk, but it is actually a universal thing. So that's important. Ananda, did you want to comment on anything particularly before we start addressing your questions from the webinar participants?
Not at the moment. I think we'll take the questions as they come. I think we've laid the groundwork and we should move on.
Brilliant, thank you. So Lucy, I know you've got a bank of questions there, so perhaps you could direct some towards us.
Apologies, lots of comments, not just questions that have come in. So one of the questions that came in is, did we look at how senior the individuals were, or are they mostly SAS doctors and junior nurses or senior colleagues in management roles? How much is it to do with structural inequalities contributes to this?
Yes, I mean, Tim, you're probably in the best position to answer that from the data you have, and you did tell us a little bit about the structure of your groups, but I don't know if you could elaborate on that a little bit.
Yeah, we didn't get absolute clarity on that. So if you remember, we're relying on tweets and vignettes in newspapers, some of which were duplicated from one media outlet to another. But we did triangulate the information, get as much information as we could. There was a sense that individuals were not the most senior. So there were, amongst the doctors, there were individuals who were in their 50s working in locum positions or in registrar positions. There was a fair number of SAS doctors within the nursing fraternity. It's not fraternities, it's sorority, and the other health support workers. There was a tendency to feel that that perhaps people were not in the senior ranks of their profession. But of course, a lot of people are in those lower ranks, and without doing a formal analysis, all it is an impression. And I'll be a broken record by the end of the webinar. We need better data and better analysis.
Yeah, Farah, please.
I think that's an important observation that the people attending are making, and clearly we need to be able to empower our whole team. As Cliff said, it's not just the surgeons, we're part of a much bigger team, and it may be that the people who are doing healthcare workers, maybe some of the junior nursing staff or our surgical team members, don't feel empowered to be able to say, actually, I think in this situation I need this. And maybe that's the message that we need to sort of encourage them and support our teams. I'm sure there is an effect of that.
Yeah, I mean, this is one of the things as we get more granular data, hopefully it will inform us about how we work and how we can work better in the future when we get through this crisis. But Ananda, please, you wanted to comment.
So I echo that point, and I think initially the guidance from Public Health England was more pragmatic in terms of the fact that we just didn't have the level of PPE that was required to equip everyone. Yeah. And patient contact, and I think this shows beautifully in the data, even though it's been described by its author as scruffy, it's the best we can get with the data that we have at the moment. There are no anaesthetists and no intensivists who died. And I think that's because they were recognized as being at the higher end of risk, and they took the best PPE precautions right from the get-go. Whereas most of us in the other specialties were dealing with patients within a meter, and as surgeons are most affected, we were examining patients physically without even a surgical mask or other precautions in the initial stages before Public Health England changed the guidance and said that if you were within 3 feet, you needed a basic surgical mask, if not an FFP3 mask. And that's part of the problem, I think. And I think Farah's point in terms of the fact that the more junior, the more transient, and the less established people in these roles, including the healthcare workers, felt that that was not the line taken to provide them with PPE was not an established one, and they were hesitant to possibly ask for it. This will come out in the wash, but at the present moment, I would agree with that feeling.
And I hope, I mean, people bear in mind too, as I say, now we're starting to contemplate non-emergency surgery. There's a general feeling of relaxation, and now's not the time to forget about these points, the issues you've all raised, which are really important. And I hope that the guidelines that we're putting out and we keep on elaborating as we get more information will be helpful for all members of the surgical team, as you say. So Lucy, can we, any other questions that we should fit into this?
It's really nice. There's lots of people kind of agreeing what the panel is saying. So there's one question, I'm not sure whether anyone would know the answer to this, but whether there is a link between vitamin D levels and whether the panel have an opinion on this.
Tim, I'm sorry I'm relating to you, but you're the evidence man at the moment. And I know you've actually commented on that, and there's been some comments. Otherwise, I mean, I've done a little bit of background on it. I don't know if you have any views, Tim. And Farah, you want to mention it as well. So Farah, do you want to go first?
Well, certainly I've read a number of reviews trying to look at these interactions. I'm no expert in it, but in Wales, we've actually had our risk assessment forwarded to all our health boards, and part of that is advice that all BAME healthcare staff take vitamin D. So that's what I plan to tell my family to do as well. I think there is some evidence about how it interacts with infections, and there was work on SARS. I'm not an expert, but I think it seems perfectly sensible, personally, to take vitamin D. And as I said, that's what the Welsh Government are recommending to all their healthcare staff of BAME backgrounds.
Yeah, and I think it's another one of the points that Tim made as well. I mean, when I listen to that data, there's an enormous number of questions that come to my mind, but in surgery alone, we can't answer those questions. That's why we're so supportive of detailed data collection. So these sort of questions then can be analysed and answered with some certainty. So I think that is an important point, but it's again one of these questions we need more data on, and hopefully we'll get that. So Lucy, any other questions? Oh, and some of the comments would be interesting to hear as well.
Yeah, no, absolutely. Let's do that. Any move towards vitamin D levels measurement as a screening for BAME groups on the front line?
I kind of think we might have addressed that a little bit in the comments. You know, Farah's raised the point of taking it, and obviously more data. Yeah.
So the point that was raised around there hasn't been any deaths from doctors who in intensive care or anaesthetists, they're saying, is it because, and we've covered this, but they agree, and it's all down to PPE. There's lots of kind of comments that are coming through about people feel that they can't ask for PPE, or if they are, there's kind of challenges for the requests at PPE.
Yeah, it might be worth following it up. And perhaps, Tim, could I ask you, because I mean, again, yes, PPE, but Ananda touched on this point, is one thing having it, is another thing knowing when and how to use it. And I guess your teams universally use it in ITU, well, largely use it in ITU. They'll be very used to putting it on and putting it off. There'll probably be quite regular team sort of approaches to it. And is that, again, something else we should think about? It's not just demanding of PPE, it's making sure that our teams know when and how to use it appropriately. And I'll come back to Farah.
Yeah, it's a complicated and very emotive area at the moment. And as I've said, I'm not at work. I think there's been massive confusion. I think there's been poor communication about PPE, and I think there's been unnecessary complexity created around the topic. I think the sensible thing is for people to understand what they're trying to prevent, whether they're trying to prevent droplet infection, contact infection, or airborne infection. And the evidence remains, despite what Twitter says, that it is predominantly a droplet and fomite or contact disease, and protecting against that with the addition of a surgical mask in most circumstances is probably sufficient. I fully accept the point about anaesthetists standing out, anaesthetists and intensivists standing out as not being visible there. But I think the first principle is that individuals need to understand what they are trying to prevent, And what follows from that is a logical use of PPE, because I don't think there is a mandate for simply putting on as much armour as you can. Putting on too much armour probably means an increase in self-contamination when taking it off. It certainly means that it will run out as a resource, and it's an unpopular thing to say, but it may be one of the things that becomes rate limiting in treating patients with COVID and also with restarting planned and elective surgery. So it's a really complicated topic. And while I think there is a signal in the data, that needs to be explored further.
Okay, thank you. And Farah and then Ananda. So Farah first.
I think it's, like Tim said, it's a complicated issue, but I think the data does show that if you wear the PPE in the high-risk areas and you wear it properly, and it's part of the whole package of infection control, then it works. I don't think we can deny that. I think maybe we should be reaching out to groups who are in the intermediate areas which are thought of as not as high risk to ensure that they know how to wear it effectively, appropriately, and also, as I said before, are able to ask for it and have a sort of sensible conversation rather than be driven by there isn't enough or pragmatic things. I think it's a balance, but I also think we need to think about other things like social distancing in hospitals. It's not easy to do, certainly not when you're in the working environment, but when you're going to have your rest or walking down the corridor, all these other things, because we're not, healthcare staffers aren't immune to passing things on to each other. But I think the data shows that PPE works when done properly. So more training, more teaching, more empowerment to the staff.
Thank you, and Ananda.
So I think this again comes down to the the initial guidance from Public Health England was that if you thought that the person you were dealing with, you suspected that the person had COVID, or the person was known to have COVID, then you could make a case for PPE. But in the initial stages, the advice was that unless the person fit into these two categories, you did not use personal protection, including in the form of a surgical mask. I don't mean an FFP3 mask. And I think that is where the problem has arisen. And because most trusts followed PHE guidance, that was the line that was taken through. And remember, we did not have a chance to get full PPE to cover the entire workforce, including HCAs, etc. at the time. So that was also pragmatic. And that is, so if you look at it, when you are speaking to someone and you notice that they have bad breath, smell is a particulate phenomenon. And the fact is that a particle has come through from the person's mouth during speech and has landed on your mucous membrane of your nose, and that's how you smell it. And if that can happen, a virus could easily be transmitted the same way. I'm not saying that it's the main method of transmission, but if you use that as a common or garden reason to wear a simple surgical mask during consultations less than 3 feet, which is what PHE recommends now, then I think you're fine. And I can't understand people who say today that you are examining and seeing people face to face with less than 3 foot distance without a surgical mask. And I think we do need to make a case to say that it has to be available for you to do that.
I mean, Nanda and the others, I mean, one of the approaches that we've taken, as you know, because you've all been part of it, is to try to give guidance to the surgical teams, not necessarily about specific things, because the data and information is so complex, as Tim has alluded to, and it varies depending on local environments and so on, but to give them the sort of questions or things they should be thinking about, because as Tim has alluded to, it's a fairly complex area. It's better that people think about it logically and use the guidance rather than sort of adhere to an absolute yes or no type approach. I mean, it'd be interesting to know if any of the webinar audience have used or think those guidelines would help, because obviously we're open to wanting to improve them if necessary and refine them as we go along. Perhaps we should move on, Lucy, because I'm conscious, other topics, but I'm sure we'll keep coming back to this area because it's so important.
Of course. So a question about individuals who are partially shielded and being redeployed to to COVID negative being redeployed and not to be exposed to COVID positive cases. But is this the case that they're increasing their risk because they're moving away from being in full PPE?
I think that's a really interesting question, is one I've been personally thinking about. It's not only because they're moving away from full PPE, that they're also possibly moving away from the team that they're used to working with and in the environment they're used to working in, which I think are important questions. I mean, the other panel members might have some comments, but I think there's been really good examples of how trusts around the country have actually risk assessed individual members of teams and then actually help them to work in a way which is productive and safe for them and the rest of the team around them. So I think it does depend on the local environment and help and support. And there are some good examples around the country of how that's been done. But has anybody else got any views or comments on that on the panel? Yeah, Tim.
I think it's a really good question. One of the problems I think at the moment is that we simply don't know the prevalence of the disease in the population or within hospitals. And so we started, as Ananda was saying, early on in the epidemic, with treating patients as potentially COVID, wear PPE, or not, don't really wear anything. And at some point, we'll go back to that. But for the time being, I would imagine in pretty much every hospital, the majority of patients are being treated as at risk of PPE in surgical settings. And that's logical because we don't know the risk. And individuals will know of anecdotes where patients have been risk assessed as of low risk, but have passed on infection to multiple individuals. And it's not worth taking the risk, frankly. What we need to know is the local specific information about prevalence within the community, which might tell us about the risk of patients coming into hospital and their risk of having COVID. But also we need to know the prevalence of the disease and in due course antibodies in those people working in surgical and anaesthetic teams looking after patients, because there's a risk of infecting patients. So as we move towards stage 2, phase 2, and trying to restart planned surgery, we really need that information. At the moment, the antibody tests aren't sufficient, but in due course, we need information about the prevalence of the disease and the prevalence of immunity from it. It's complicated, but I think that will then guide us as to those circumstances when we should be wearing PPE. And I think probably the majority of people at present will be treating everybody as potentially COVID positive.
Okay, I mean, I just have to interject that we've been working actually today on guidelines for surgical teams to actually accompany the guidance we put out last week, and there'll be some sort of tools section, if you like, just one pages about what considerations you should take about exactly the points you made, and they'll be on the website next week. So just to sort of advertise that, I hope that would be helpful. But Ananda, you wanted to comment on this issue as well.
Exactly the same point, that once we move to doing some elective work, there's the question of diagnosis, both of staff and of patients, and how frequently do you do it? And I think rather than testing everybody every day, which is completely wasteful and still, given the inaccuracies in the RT-PCR for antigen testing, I think we are going to depend to some extent on a good serology test. And if you do have a reasonable titer of antibodies, then I think some of this problem is likely to be parked for a while until we can get a vaccine. So I think opening up is not going to be a straightforward process. I think it's fraught with risks, possibly even more fraught with risks when we first started this process.
And what does seem to be emerging is that COVID-free or COVID-poor environments, if you like, are the safest environments to contemplate doing non-emergency surgery rather than organisations where it's compartmentalised. But that's obviously difficult for some areas, and we'll see that emerge. Lucy, any other areas?
So one of the questions is, there's an article that's been published indicating high infection rate in hospital environment. This is among staff and patients. What do we know about infections within hospitals?
I don't know if anybody on the panel, we were talking about this today, funny enough, at one of the college meetings, and it seems to be that it's patient-to-patient infection and staff-to-staff infection, not so much between the two groups. And so that's why there's been a lot of work done to think about social distancing being maintained within the teams within hospital and healthcare environments being so important, and for all of us to take on that responsibility to minor cells, and then the understanding of the community from which patients are coming from, the sort of thing that Tim alluded to, you know, the prevalence of COVID in the community, and also the community that they're going back to for rehabilitation after any surgical treatment they might have. In terms of absolute rates, I don't know if anybody on the panel has any information. Tim, thanks.
Yeah, there's a study from Holland where they did surveillance of staff within a hospital, and it's the only study I'm aware of. There may be others, but they found a 6% incidence of COVID. I think it's closer to 7% incidence of COVID amongst healthcare staff, most of whom were either asymptomatic or very mildly symptomatic and were still at work. So that potentially creates a risk for the patients as much as anything. And I think I agree with you, Cliff. There is a reasonable amount of data that the transfer of the infection seems to involve reasonably close contact for more than a few seconds, so sort of proximate and prolonged contact. So things like transport and being at home are those locations where people are most likely to catch it from other individuals or to pass it on. And I guess working with colleagues as opposed to very briefly seeing a patient or passing someone in the street might be relevant factors there.
Panel.
Just while you're talking about that, Tim, can I just ask you very quickly, I think something quite important that a few people have asked me, does the type of anaesthesia, so if you're a surgical team planning to operate on somebody, does the type of anaesthesia make any difference to the risk? So if it's an inhalational intubated patient composed with a spinal or local anaesthesia, because that's something that a lot of people are asking at the moment.
Simplistically, the answer to that is if the patient's awake and breathing for themselves and is not coughing, then they're not a great risk to anybody. If you have pressurized the airway and it is not sealed, then you are potentially aerosolizing virus during the case. But providing the airway is sealed, a sealed airway, whether that be with a supraglottic airway or tracheal tube, should be safe during the procedure. And what creates safety is the ventilation, the clearance of the virus from the theatre. So for every air exchange, which in theatres is usually less than 5 minutes, you clear about 65% of the virus. So after 2 air exchanges, you're down to 14% left, and after 5 exchanges, you're down to less than 1%. And that's where what was a 20-minute rule has now become a 5-minute rule comes from.
Okay.
But if you've got a patient who's awake and coughing and sneezing all over the place, I don't think that's particularly safe.
Right. Okay, that's really helpful. Thank you. Ananda.
Tim, just a little question. Now we use positive pressure both in theatres and the laminar flow when we're operating. I know that friends of mine who work in New York have reversed it, have negative pressure in the theatres where they operate. And the reason for that is you are titrating the risk to the patient of picking up an infection. And if you want to limit that, you have positive pressure and laminar flow. But in your ITU beds, we have negative pressure to decrease the risk to the carers. Do you have any views on this?
I think flow is far more important, and air exchange is far more important than whether it's positively or negative pressurized. As someone said on Twitter, the positive or negative pressure simply determines the route of egress rather than the speed of egress. What is important is that airflow is maintained, and turning off laminar flow or turning off ventilation is the wrong thing to do. You want to maintain flow. There may be a virologist or microbiologist who would give you better information about the importance of positive or negative. But the reality is that negative pressure rooms are actually pretty sparse in the UK. Most intensive cares are positively pressurized, with a very small number of side rooms being negatively pressurized. So it's quite difficult to find negative pressure rooms.
Okay, thank you, Tim. I'm conscious we've probably got some more questions, Lucy, so can you guide us towards...
Yeah, of course, yes. So it's how does the BAME community, so if you're talking about non-BAME people with comorbidities such as asthma, diabetes, how do they compare?
Okay, I take that question to mean in terms of their risks, rather than how they should be advised or handled, but assuming it's the former, I mean, let's just whiz down. I mean, Tim, do you want to start off, and then Farah and Ananda, any comments on that? So non-BAME members of the team who have other risk factors. Again, you talked a little bit about age, obviously the young females, things like that, but there are quite a few risk factors which are emerging, I think.
And I think it's another area of mass unknownness. I think what's absolutely clear is that age is really important. So as I said, 75% of all UK deaths from COVID in the 70% in the over 75s, 90% in the over 60s. So age is the major factor. The problem with all the analyses is that the comorbidities probably cluster. So if you're elderly and obese with diabetes, you may well have cardiovascular disease and or COPD, and hypertension. So those things cluster, and that may also be an issue in BME populations. What we need is a large data set which is analysed with logistic regression, so we can try and extract some of the really important factors in addition to age. We haven't currently got that, but we should be getting to the size of data sets where people can work on that.
Looking at the national data sets, the other big factor that seemed to determine a bad outcome was obesity, and I don't know if that's probably not enough data in the medical in their healthcare workforce yet, I guess.
Obesity will move with some of those other factors, hypertension, diabetes, even with age to a certain extent. We all struggle as we get older. And certainly the ICNARC data, the distribution of obesity within the patients who are in ITU, and of course they are a subset and might be selected, doesn't vary dramatically from the population norms, and the poor outcomes don't increase until people are pretty heavy, sort of morbidity, BMI above 40. It's easy to overstate, I think.
No, thank you, I appreciate that. So, if somebody else wants to comment, should we move on to some more questions, Lucy?
Yeah, so after all the discussion that we've had, what's the college going to say to Trust about how better to protect the BAME staff?
Well, if I may start off, and then I'm sure Farah and Ananda will want to comment on it. We have put in our guidelines that the most important thing is to consider the use of PPE and it's used appropriately. And also testing is very, very important, because it seems to be protection is the most important thing for all members of the healthcare team. We also support the concept which was put out by Simon Stevens last week, that those individuals, and we've had some questions on those, I think, who have added risk factors or consider themselves to have added risk factors, should have a risk assessment by their local trust through occupational health or HR. And if they are considered to be, and they consider themselves to an increased risk, then appropriate measures should be taken to actually protect them, as along the lines we've already talked about. So that's my understanding of it at the moment. I mean, if I hear the data and look at it, the thing that stands out to me at the moment, while we're still trying to understand this condition better, as Tim keeps alluding to, is it's about protection. Is the key to everything, and that's, you know, and I'm delighted to see the ITU and critical care results, because, you know, there's a group of people who really have taken this on the chin on the front line and yet have managed to actually protect themselves. That's remarkably good news for them, but also I think for everybody. It gives us a guide at the moment until we have better understanding. But please, Farah, you talk.
So going back to the
about this initially at the beginning, I don't know if you want to add more to that.
Sorry, I was just saying that going back to the previous question about a non-BAME person who has asthma or other morbidities, I think at the end of the day, what we're looking at is some analysis of the people who have unfortunately died as a result of COVID, and trying to get some more granular data as to how we should weight, what weighting we should give to the individual risk assessment for the various factors, as you asked, about obesity, hypertension, and ethnicity. So the weighting for ethnicity is yet to be determined because we just don't have the data. It was difficult enough doing the fairly simple thing, getting the numbers and the ethnicity of people through Twitter and various other media. This data is not being measured. It will be measured from Friday, but the people who died, we do have some basic data of their weight and the other comorbidities that do exist. And we should be using that and trying to allocate some degree of weighting to each of these, so the individual risk assessment will be a little bit more meaningful.
Yeah. Farah, did you want to add anything? Yeah.
Yeah, I think the question was, what do people do, or what the college is advising? I think we've already said that we're keen that people get risk assessed and then appropriate measures taken, whether that's more PPE or redeployment. As I said, in Wales, we're a little step ahead in that all health boards have been asked to contact all BAME healthcare staff, whether they're surgeons, nurses, healthcare support workers. So I would advise people to proactively go and ask, well, think about yourself and your own risk factors. We'll all be different. You know, I'm hypertensive and I'm a little bit over 50, but I think people have to empower themselves to go and sort of talk to their line managers, talk to their team, their consultant, their lead nurse, and say, and have a sort of conversation, be proactive about it if your trust isn't being proactive themselves.
And I think it's also worth just reiterating that we do have a confidential helpline and support line for people who feel that despite that advice, they're still under undue pressure or duress. So hopefully the local organisations will address this, and certainly the evidence so far I'm hearing is that they are, but there's still the opportunity for people through our college, if they feel that despite doing those things, they're still actually struggling. And that's what that line is for, which is up and running at the moment. It's been running for 2 weeks now. So Lucy, want to...
So the final question, our members are surgeons, but they're also dental surgeons and dentists. So does the panel have any views on the kind of the risk to dentists?
Yeah, well, I apologise that we haven't got a dentist on our panel tonight, but everybody knows, I think, Professor Micah Scudier, who is a dental surgeon and who's been leading on this, and actually has been incredibly effective at drawing attention to this area. And I'm sure if he is on here tonight, he would be banging the table about it. He's been talking to government, he's been talking to dental associations, and been very, very powerful at getting this recognised as a high-risk area. And of course, again, it's balance between reintroducing some non-emergency work into the dental practices, but doing it appropriately and safely. And so Mike has been leading on that. There are clear guidelines available for that. And I think he's well ahead of the game there. But again, others might want to comment on that. I apologise that we haven't covered dentistry because of the nature of the panel tonight, but it's certainly, as a college, it's been very high on our agenda, led very much by Mike, who's been excellent at it.
There was one dentist and one other healthcare worker in a dental practice. I can't quite remember the details of that individual, but there were two people in the dental sector. I think one was non-clinical, who were in our list of fatalities. One of the problems with the data, of course, is that those people who died probably acquired their illness at least 2 weeks, if not longer, before they died. And so our data that we published was truncated at about the 20th of April. So we've not got much data beyond April, and even the changes in PHE PPE advice that Ananda referred to, those came in the first week of April. So we won't really be seeing the effects of that probably until data that starts coming through this month. So there is, as I've said before, a pressing need to collect the data, analyse it and report on it in a central way.
Okay, Lucy. So I think that's our questions for this evening. So what I'd like to do is just to draw this to a conclusion. I think we'll look at the comments and other questions that we haven't had time to answer tonight in some detail. And as I said at the beginning of this session, those are really useful to us because it helps inform us how to represent you as our colleagues, and also where areas need to be represented more strongly. And I thank you for all the effort and input you put into the questions and comments tonight. I'd just like to finish off by thanking the panel members, Ananda and Farah from the Council of Royal College of Surgeons England, and Tim in particular for really bringing this to everybody's attention and for handling all the data questions so expertly tonight. It's been really helpful, and thank you very, very much for that.
Absolutely.
And I hope we can continue to work with you because you've been very helpful to us, I think, giving us some information about things that we as members of the surgical team need to understand more clearly. And as I said, sorry, Tim. Did you want to say something, Tim?
I was just saying it's an absolute pleasure, and I'm pretty easy to get. I'm happy to be contacted in the future.
I think we might take you up on it. Thank you very much. And as I said at the beginning of this, setting sessions up is no mean task. And I'd really like just to again thank Lucy, Jane, Tamora, and Misha, who have all been handling this amazingly well and made it much easier for us as panelists to get this done. So thank you all very, very much. And I look forward to the next webinar session. So good night, and I hope everybody stays safe, and I really welcome any feedback from tonight's session. So thank you all very much.
Good night.
Bye.
Bye.